Okay, so what I was telling you about MAO and COMT. So now you see, the another important thing which you need to remember regarding the MAO and COMT is that MAO and COMT do not cross blood-brain barrier. Please remember, they do not cross the blood-brain barrier. They do not penetrate the blood-brain barrier. Okay, please remember this. So if you don't mind the recording and let's begin. Okay. So uh, whenever the lecture stops, please you people uh, go to the WhatsApp group and just check the link if it is working. If it is not working, I do paste the other link. Okay, so just try to come as soon as quickly as possible. So that we can finish it on time. So now you see, like, please remember the student in Mars if you're late, Maria. I have told one more point. That was MAO and COMT do not COMT. Okay, they do not cross blood-brain barriers. Okay, they do not penetrate the blood-brain barriers. Okay, so please remember, I'm talking about the drugs. Okay, so the drugs that act on these, they do not penetrate the blood-brain barrier or penetrate the CNS. Okay, and all this norepi, dopamine, okay, all of them are metabolized by these MAO and COMT too. Okay, so please remember these things. Now, this was all about your synthesis. So let's see what they have written over here is um, postsynaptic receptor is activated by the binding of neurotransmitter. So definitely we know this thing. And then how norepinephrine is removed. It is either taken up by this is a norepinephrine transporter, which we call NET, okay, norepinephrine transporter. It takes up the excessive norepinephrine. Do you remember the cycle of acetylcholine up there? What was happening in acetylcholine was this, there was an enzyme acetylcholine esterase that was breaking this acetylcholine into choline and acetate, and then this choline was taken up from here. Okay, but in norepinephrine there is no enzymatic action. This neurotransmitter takes up the excessive norepinephrine that is left in this space. Okay, and then COMT is present. What it will do, it will break this norepinephrine into inactive metabolites that will be passed into the urine, and I just told you one of them is BMA. And first of all, metanephrine, normetanephrine, like norepinephrine will have normetanephrine, and then normetanephrine, and then the other one will be BMA. Okay, epinephrine will have metanephrine and BMA. So from that chart which we just saw, I am like concluding it. So the important thing here again is drug. So we have studied this reserpine drug at the level of the uptake of dopamine to synaptic vesicle. We have read these two drugs, guanethidine and bretylium, that were blocking the release of norepinephrine into this space. Okay, and then we have this drug cocaine. So cocaine is basically not a drug. It is used as abusive drug. Okay, not as a therapeutic drug which we give in clinics or hospitals. So cocaine is an abusive thing. So cocaine, and then the drug imipramine. Imipramine is a very, very good drug. So both of these drugs are used at this level. They inhibit this transporter, norepinephrine transporter. They just inhibit this so that norepinephrine will not go in here. When the norepinephrine uptake is not possible, the norepinephrine stays more in this synaptic space, okay, and will perform more action for a longer period of time. Okay, so please understand these mechanisms, because when you will be studying antagonists, adrenergic antagonists, you will be focusing on this receptor alpha 2. You will be focusing on the COMT. You will be focusing on this norepinephrine transporter blocking mechanism. The drug will block this mechanism, and more norepi or epi will left in this space. So remember, the reuptake is inhibited by cocaine and imipramine. So now you understand what cocaine do. When people take cocaine, how it helps, it just stops the reuptake. So that is why the patient is always in that euphoric state, because it exceeds the normal sympathetic activity that is going on in our body. It exceeds that to another level. Okay, so that is why cocaine makes a person euphoric. And the last step is metabolism step, which I already explained you, COMT and MAO2. So MAO2, okay? So please people remember these things. Then also in this picture they have explained you that the dopamine MAO will metabolize it at this level, and then its inactive metabolites will also go into the urine at this level also and at this level also. So not only at the level of synaptic space COMT is working, but at the level of neuron MAO is working. So please remember the location. COMT location is postsynaptically, and or we can say in the synaptic space, and MAO is intraneuronally. Okay, please remember these differentiating points. So I think now the synthesis is pretty much clear to you. If you have any question, you can ask me, and I'll take you to the receptors from your first aid book. Okay, because we have where is the first aid book? Okay, so because we have to study these drugs. Okay, so before studying these drugs, in the similar way when I was teaching you cholinergic, so you see the synthesis is also given in here also. This is your first aid picture. So the synthesis is also given over here too, and they have also, it's not like that I am telling you things that are not present in your book. Okay, and I'm focusing on that. You see they have talked about reserpine. Okay, they have talked about the inhibitory drug cocaine, and we in that book it was written imipramine, but you can see amphetamine. They belong to the same class. Okay, it's the same class drugs, and tricyclic antidepressant TCAs. So they all work on this net transporter. So you see it's also like it is also a part of your first aid book too. So they are important things. And then alpha 2 receptor, as I told you, okay, and we will be talking about this 82 later, because it will mix the concept. It is some at some other level we will talk about it. And then what else? I told you about this calcium depolarization, that it will help bind this synaptic vesicle to this membrane via two things. One of them is called synaptobrevin, okay, and the other one is called syntaxin. So please remember these two names, okay. And then one thing is this, okay, amphetamine and ephedrine. Okay, we will be studying these drugs. These are not inhibitory. In that picture, we were only talking about the inhibitory ones. Okay, blocking uptake, blocking release, blocking uptake in the synaptic vesicle. So we were talking about all this, blocking reuptake. So, but this is a positive drug. Okay, like it is activating this norepinephrine transporter to make norepinephrine reuptake more and more. Okay, so we do give these ephedrine and amphetamine to patients, okay, when there is like more drug left in the synaptic space, and there is like a condition like in which your sympathetics are activated, okay, because they are like non-catecholamines. So we have we have catecholamines and we have non-catecholamines. So this phenylephrine or ephedrine or amphetamine, okay, they are called non-catecholamines, and they penetrate CNS. The important thing is they penetrate CNS. Okay, their duration of action is also very longer. So we will be studying these non-catecholamines in detail here. So don't worry. So this is the picture of your first aid, and we studied the previous picture of this, like of cholinergic and adrenergic. So now you can also read this all thing, okay? Too. But if you have like left any point, and you can ask me if you have any queries, okay? So my point was to take you back up to these receptor levels, because when I was teaching you cholinergic, I haven't touched when I was teaching you cholinergic, I haven't touched this part. Okay, I haven't touched these receptors. I taught you only this. So we have studied we have studied this cholinergic thing already, but we haven't studied the adrenergic thing. So we will be focusing on adrenergic and dopaminergic right now. So another thing, do we have a question? No. If you have a question, you can ask me. No, almost forget to close this pen. If you kind of remember, I have already taught you people this this all page. Okay, we have discussed this in neurophysiology too, and we have discussed in the previous lectures of pharmacology too. So, but like in order to make a good view, good concept, so that we can touch our our first aid, I have divided the functions of alpha 1 according to their locations to make it easier. So the most easiest way to understand is just remember the overall function. The overall function of alpha 1 is constriction and contraction. Okay, so now when you see this constriction and contraction in a bigger picture, you will see that at the level of vascular smooth muscles of your skin and of your splanchnic regions like your gut, okay, your intestines, you will see the vessels are constricting, so you will see vasoconstriction. When the vessel wall will be constricting, it will be applying more pressure to the blood. Okay, that is how, because of the constriction, the blood will be applying pressure to this wall. That means increased total peripheral resistance. What is total peripheral resistance? When your blood inside your blood vessel exerts pressure on your walls of your blood vessel. Blood is exerting pressure on the wall of your blood vessel. When that pressure increases, it is called total peripheral resistance. In the simpler definition of total peripheral resistance. Okay, and um, this total peripheral resistance leads to increased blood pressure as a whole that you see in your like textbook. Okay, when you study your textbooks, you see at written like increased BP, or when you see your blood pressure, monitor your blood pressure via an apparatus, your systolic and diastolic blood pressures are raised. Okay, your cardiac output is increased. So the basic mechanism going on behind is vasoconstriction, simple one. Okay, so anything that will bind to alpha 1 like epi like norepi, like dopamine. But dopamine normally do not bind, so we will talk about epi and we will talk about norepi. So any of the drug that will bind to alpha 1, it will cause vasoconstriction at skin level and splanchnic region levels. Okay, in the vessels, in the vascular smooth muscles, vessels. Okay, what happened in the splanchnic regions? The GI motility will increase because the circular muscles, we have two type of muscles, longitudinal and circular. In your small intestine, you have longitudinal and circular. In your stomach, you have longitudinal, circular, and transverse. So you have three set of muscles in your stomach. So please remember, we are talking about the circular muscles only. We are not talking about longitudinal or transverse. Okay. So the circular muscles will contract more, contraction. Okay. So gut motility will increase. Side effects will be diarrhea. Okay. So if you remember this picture, you will remember the actions, you will remember the side effects, you will remember the mechanism of action, also everything, like, you know. And then radial muscles of the iris. So radial muscles constrict, making ciliary muscles relax. So I always, like I have repeated this concept 1,000 times now, that you have this lens, you have this iris and ciliary muscle. So when your ciliary muscle will contract, your iris will become thinner and elongated. Okay, thinner and elongated. So please remember this concept. And your ciliary and your radial muscles always work together, but in opposite mode. One will relax, one will constrict. So the process of mydriasis, that is pupil dilatation, you will see ciliary muscles relax. These ciliary muscles will relax. When they will relax, let's say like this, your iris from, if I draw it first like this, and then I take this another color and I will draw it like this. So the red color one you're seeing is normal and the blue color one is relaxed. Okay, and if I have to label them for you, this is iris and this is ciliary muscle. Okay, and your lens is present here. So there is this same structure present here too. So when both of them will relax, you are giving more space for the accommodation of light, and that is you call mydriasis. Your pupil is dilating when your iris are going back. When your irises are going back, you're giving more space. When your irises are coming towards each other, you are giving less space, okay, for the accommodation of light through the pupil. So please remember this mechanisms. If you have taken classes of cholinergic drugs, I have shown you multiple pictures to explain you this whole procedure. Like I'm repeating it one more time. Okay, and then your radial muscles are present around your pupil, like here. So they both work in opposite fashion. Please remember this. Okay, and then we have constrict bladder sphincters. So again, this concept is important. You have this bladder and you have this sphincter. So your detrusor muscle of the bladder works opposite to your sphincters of the bladder. If your bladder sphincters are constricting, your detrusor muscle will relax. If your detrusor muscle is contracting, your sphincters will relax. They also work opposite, okay? So now when you are constricting your bladder sphincters, that means you are not allowing urine to pass. When you are not allowing urine to pass, that means your detrusor muscle is not contracting. Okay? What happens is when, like, for example, you have drunk a lot of water and you are sitting on a chair when you want to urinate. You are feeling that now I should go to the washroom and I should urinate. So what is the thing that is going inside your body? The pressure receptors present on this detrusor muscle will sense pressure of the urine that is causing pressure on the wall of detrusor muscle, the detrusor muscle will contract, okay. uh, the pressure receptors will sense the pressure, they will go to the central nervous system, okay, they will give the signals. In return, the response will come, the detrusor muscle will contract, the sphincters will relax, and you will pass urine. But in the opposite, when the opposite thing is happening, when your sphincters are constricting, the detrusor muscles are relaxed, no stimulus is going to your central nervous system, no response is coming. So there are drugs that work on these bladder sphincters, and there are drugs that work on your detrusor muscles too. Okay, and we will be studying all of them one by one in every system in more detail. Okay, so please remember all these things. There is another, if you have like checked my physiology folder, there is this pictorial diagram, okay, that I have explained every page of this, okay, in my lectures. So please review all the old lectures. I have like, even the students who are not taking my physiology classes, I have added the physiology lectures to your Google Drive, only because the basics are same in these topics. So you see the urinary bladder thing, this is your sympathetic, the red one is your sympathetic and the blue one is your parasympathetic. So when you are seeing this sympathetic, the nerves are doing the same functions. In case we are talking alpha 1 receptors at the sphincter level and they are constricting, so this hypogastric plexuses that are coming to your urinary bladder will work in an opposite fashion and it will inhibit it. If this is inhibitory, this is positive. If this is positive, this is negative. So please remember, okay? So I have explained all these pictures in physiology lectures, previous pharmacology lectures. You can go through this all things, these all pictures. These are very good. These are very good pictures, okay? So there are plexuses in your uterus. They have written the name of plexuses. They have shown the um, levels. They have shown these levels from where these nerves are arising. Okay, your genitals, your urinary, your lacrimal glands, your parotid glands, your salivation process, your adrenal, your parenchyma of your kidney. Okay, so the one I was talking about of adrenal medulla too, and then your heart, your lungs. Both sympathetic and parasympathetics are given. Okay, from the segments to the autonomic ganglia to the organs. So please, if you are having like any trouble, you can also ask me, so I can explain you one more time if it is possible. So when we go to our textbook now, in your textbook you will see that in alpha 1 we have this increased vascular smooth muscle contraction, as I told you, okay, that will increase your total peripheral resistance. You can also write in your book, okay, that will increase your blood pressure. So, okay, then increased pupillary dilator muscle contraction will cause mydriasis. The mechanism of action is in that notes, and that notes is in the Google Drive, okay, so you can like have it from there. And increased intestinal and bladder sphincter muscle contraction. So all of these things are same that are written here, but because this is your textbook, they have not explained how. Okay, so the how is explained in the notes, so you can refer your notes with it. Then I have given you a whole lecture on G protein class, the second messenger system. So go back to your pharmacology previous lectures to check the Q, I, and S. Okay, so If I repeat it, it will take more time. I have explained this whole process, okay? Then we have this alpha 2, okay, inhibitory response that I told you. This is a presynaptic neuron, and here the receptor is alpha 2. So what alpha 2 does, it decreases everything. So you will see decrease arrows, okay? It decreases everything. And if you see this increased platelet aggregation, so when the platelets are aggregating, what happens? Decrease blood loss, okay? Blood loss is decreased. So basically it is like inhibiting everything, okay? And I told you that they are present on your pancreas beta 2 receptors where insulin is released. So this is the one organ you have to remember, okay? And for others, they are working on the neuron level and causing these aqueous humor production low, lipolysis decrease, platelet increase. So they are working on the neuron level. But for insulin, they are working on, they are working on beta 1 cells, okay, of pancreas. So please remember these things. Then we have beta 1, beta 2, and beta 3. So if I take you back to my notes and let's see. So I have written regarding alpha 2 too, that how it works, and I've drawn this little diagram over here so that you can explain it in better case, that alpha 2 is like has this inhibitory G inhibitory second messenger system. So it will like decrease everything, decrease cyclic AMP, will decrease the phosphorylation. Okay, so all the effects will be opposite of alpha 1. Whatever alpha 1 is, whatever alpha 1 is doing, or whatever norepinephrine or epinephrine is doing, the functions will all be opposite. Okay, so because we are studying the adrenergic, so number 1 is your action, but acetylcholine is like the cholinergic thing. And then increase insulin release, the same thing is written. It is present on the walls of GI tract, so it will decrease the GI motility. Okay, platelets, it will increase the platelet aggregation. More platelets will be aggregated, so decrease blood loss. Okay, and in the fat cells, it will decrease the lipolysis. But here I have mentioned the beta 3. So you should remember that the fat cells have alpha 2 and beta 3. Alpha 2 decrease lipolysis, beta 3 increase lipolysis. So understand this mechanism, okay? Please understand these two opposite functions. Okay, alpha 2 decrease lipolysis, beta 3 fat cells increase lipolysis. Okay, and then so basically fat cells, like we are talking about the adipose tissues. Okay, we are talking about the adipose tissues, and I will explain you the mechanisms when we will be studying endocrinology. Okay, we have this leptin, adipoleptin, and etc. etc. So there are so many things. It will be little broader in terms. Now, if we talk about beta 1, so always remember this thing, very, very important. Ventricular muscles of heart, not atrial. Please remember. Okay, please remember. Beta 1 are not present on the atrium. They are present on the ventricle myocardium. Okay, on the SA node, on the AV node, and ventricular myocardium. But the electrical activity that is generating from your SA node to your AV node and then to bundle of hairs, right left bundle branches, Purkinje fibers, this is not a work of beta 1 or epinephrine or norepinephrine. That is a different thing. The conduction pathway is different. Okay, these receptors are only present at these levels, so that if that conduction goes abnormal, we can control that all via drugs. Okay, please make clear this point. Then what will be the functions? All positive. Positive chronotropic, increase heart rate. Positive ionotropic, increase myocardial contractility. Don't let CNC meet each other. Okay? Iono is for contractility, chrono is for rate. Okay? Chrono is for rate. Iono is for contractility. So don't make CNC meet each other, please. And then we also have a dromotropic effect, that is conduction velocity. But I have not mentioned conduction velocity here because of the reason that these receptors do not work on them. They have an indirect effect. They work on rate, they work on contractility. Because of rate and contractility, the after effect is positive conduction. Understanding my point? Direct action is not on conduction, please remember. And on kidneys, they are present on the renal parenchyma, not on the adrenal medulla. Parenchyma. So they will increase the renin release, okay, and they will activate RAS. We will be studying RAS in renal, okay. So this is renin angiotensin aldosterone system. So the final step, the process is started from renin, and the final step is angiotensin 2. So angiotensin 2 basically causes this vasoconstriction, and that will increase your blood pressure. Okay, so please remember this point too. And angiotensin, and then obviously aldosterone. So I missed that aldosterone step. Then we have this beta 2. So I'm quickly covering this because we have already studied this all. Okay, so in beta 2 we have this on so many levels: vascular smooth muscles, bronchial smooth muscles, longitudinal muscles. Then in the pancreas, increased release of glucagon means they are present on the alpha cells of pancreas. Okay, then bladder, the trusor muscle. Okay, then it will enhance the gluconeogenesis, that means it's present on the liver too, and uterus. So like helping the uterus to relax in the early trimesters. So people, you have to learn these mechanisms. Okay, if you will understand the function and location, it will be easier for you to understand the drugs, and you don't need to learn the side effects of every drug then. Okay, so if you read your book, the same things are written, nothing different. Okay, so in beta 1 you have increased heart rate, increased contractility, increased renin release, and increased lipolysis. Then in beta 2, vasodilation, bronchodilation, increased lipolysis, release glucose. So I've told you it's present everywhere, like in so many levels. And then beta 3, main lipolysis. Okay, please remember main lipolysis. So our topic for tomorrow will be, I just discussed this receptors and their functions, so that you may, if you have forgotten, it may help you understanding. Tomorrow we will be studying more about the D1 and D2, okay? And there are some pathways that I will tell you regarding the dopamine. So there are basically 4 or 5 pathways. So we will first have an overview of that, and then we will be going to the drugs, okay? Because when you will be studying drugs, it will help you understand better. So, in your first aid, they have not given that details, but everything is correlated. Your basics are basically correlated when you study your high-level books. So when we will be studying drugs from our first aid, you will be seeing they are all mixed. You will find beta, alpha, D, all rubbed together, and their therapeutic applications here. So the topics here are very small, and they have just covered in like 2 or 3 pages. Okay, and then we have all the side effects and beta blockers. So the important portions are now beginning from here. This page and the rest of the pages of your autonomics are important, so important. Okay, so this is called your journal pharmacology also. So we will be continuing our lecture on the D receptors, their actions, a little overview on pathways because they are like physio topics, but I will cover a bit of it. And then we will be moving to these drugs. So it will help you get all of the applications very nicely. Okay, people? If there are any questions, you can ask. We have like 4 minutes, 4.5 minutes left. So if you have any questions, please ask. If not, then I'm ending this lecture. The next lecture will be on anatomy. So the students who are taking the anatomy classes, you can like join. Okay. So the next lectures will be of anatomy, and we will be studying the venous supply of upper limb and the lymphatic drainage of upper limb. Okay, very important. So, this is all about today's pharmacology lecture. If there are any questions, you can ask me. If not, then we are like